To assess cervical range of motion at the OAA region, we will first check flexion by having the patient chin tuck and nod down. And he's able to get a good range there. And then to assess extension, I'll have the patient assume a forward head posture position and then lift the chin up, again getting a good extension range at the upper cervical region. In this test, I will be demonstrating the upper cervical flexion rotation test. So this is helping isolate for C1 or C2 hyper or hypomobility. As you see, I bring the patient's head into that full range of flexion and keep it while I go and bring them into passive rotation. And I'm going to compare the movement here, and if it's greater than 10 degrees difference, that's asymmetry. That would be a positive test result for hyper or hypomobility, or pain. Reproducing as pain could indicate cervicogenic headaches. To assess mouth opening at the TMJ, typically you assess for quality, including any clicking and popping, and for quantity. So I don't hear any clicking noise when he opens his mouth. But now to measure for quantity, I'm going to have the patient open his mouth again while I'm going to use my ruler to measure the amount of millimeters from the upper teeth down to the bottom teeth. And typically only 35 millimeters is needed for functional mouth opening, which he has by far. And then I'm going to make sure to observe the patient open his mouth again to see if there is any abnormal opening pattern. A C pattern indicates internal derangement, or an S pattern may be due to muscle imbalance, but this patient displays a symmetrical, straight mouth opening pattern. To measure lateral deviation at the TMJ joint, I assess for quality, looking for any clicking or popping, as well as quantity by using my ruler here and measuring in millimeters, having the patient show me his teeth and laterally deviating first to the left, measuring it from his two top front teeth to where the midline of the bottom teeth go, and having him deviate to the right as well, and looking if there's any decreased excursion on one side. This would indicate hypomobility. We will now begin resisted isometric testing for cervical strength. Starting with flexion, I'll instruct the patient to push forward onto my hand, which is on his forehead, resisting me there. And now for extension, I'm instructing him to push back onto my hand, and I'm resisting him there as well for cervical extension. Moving on to side bending, I'll have the patient resist my hand by pushing outwards while I'm trying to push in, and again testing side bending resisted isometrics on this side as well. Lastly, we can check resisted isometric rotation, so he's resisting my rotational force by rotating the other ways on this side as well. In this video, I will begin myotome testing of specific nerve roots, starting with C1 by resisted flexion, holding this for at least 5 seconds. Moving on to C2, I will test resisted cervical rotation. Remember to hold it to tire out the nerve root, doing this on both sides. Once I'm completed with that, I'll have the patient resist me on side bending, and resist me again on the other side for side bending for C3. To test C4, I will have the patient resist my pressure for shoulder shrug. C5, I will now have the patient resist abduction, holding this here. And for C5, he can also resist at external rotation. And I'm going to assess the other side here as well. Moving on to C6, I'm going to have the patient resist an elbow flexion. So I'm trying to push him into extension and he resists me. I compare that bilaterally, again holding it for at least 5 seconds. C6 can also include wrist extension, so I'm going to try to push him into flexion and he resists me. Again on this side, holding that wrist in extension. For C7, he will do resisted wrist flexion bilaterally. Again on this side. Hold, hold, hold. And C7 is also resisted elbow extension for the tricep. And I'm going to assess his right arm now for resisted elbow extension. Now, moving on to C8, that is going to be resisted thumb extension. Hold, 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 hold. And now moving on to the left extremity, resisted thumb extension for C8. Lastly, moving on to T1, we will have the patient resist me for finger abduction as well as adduction, just making sure to hold that to tire out the nerve root. The next test is the craniocervical flexion test. So first, with this blood pressure cuff behind his neck, I'm going to instruct him to do a chin tuck to 22 millimeters and hold this for 10 seconds and then relax. So I would progressively go up in increments of 2. So a normal test result would be having the patient use his neck flexors to inflate the cuff up to 26 millimeters and hold this for 10 seconds. So he's doing that now. And he can do that, so he has normal strength of the neck flexors, but a positive result would be the inability to hold 10 seconds at 26 millimeters. This next test is the deep flexor endurance test. So I'm going to have the patient lift his head about 1 inch off the table, keeping that chin tuck position, and I want him to hold this for 10 seconds, which is indicating a normal strength, and if he loses the chin tuck position, that would indicate weak deep neck flexors, but he was able to hold it for 10 seconds here, so he has adequate strength. In this video, I will be assessing the upper traps muscle length. So I'm going to start by flexing the patient's head and depressing his scapula. So if I'm going to start with the right upper trap, I'm going to side bend away, so side bend towards the left, and I'm going to rotate towards. And then next, to assess the left upper trap, I'm going to again flex the head and depress the scapula, and this time I'm going to side bend towards the right and rotate towards the left. And I'm looking for any asymmetries in these movements, as well as for any of the following muscle length tests, I'll be assessing for any asymmetries. In this video, I will be performing the levator scapula muscle length test. So I'm going to start by flexing the patient's neck at the cervical spine. I'm going to depress the shoulder with my hand, and if we're stretching the patient's left side, I'm going to rotate and side bend away towards the right side. I would hold this position for 30 seconds, and then if I want to test the patient's right side, I'm now going to depress the shoulder with my right hand and rotate and side bend to the left, which would again assess the right levator scapula muscle. Next, I will be assessing the length of the sternocleidomastoid. So with the patient's head slightly off the table, I'm going to have the neck extended, side bending away and rotating towards the tested side. I'll then use my hand to increase the stretch by depressing the sternum. I can then do this on the other side by again having the neck slightly extended and off the table, side bending away and rotating towards, and using my hand to again depress the sternum farther and increase the stretch. In this video, I will be instructing the patient to actively check for tightness in his scalene muscles. So first, starting with the posterior scalenes, the patient will contralaterally rotate, flex, and apply overpressure with his arm, and repeat on the other side. Holding these stretches for about 30 seconds, and then to check for tightness in the middle scalene, I will have the patient contralaterally rotate, ipsilateral side bend, and apply overpressure to stretch that right scalene, and he will do this again to stretch the left middle scalene. And the anterior scalene stretch will be done with the patient reaching behind his back with his arm, contralaterally rotating while extending, and then applying the overpressure. And again, this can be repeated by switching the arm behind the back, contralaterally rotating and extending, applying overpressure to stretch the anterior scalene. Here, I'm going to be demonstrating cervical distraction, which is a technique to open up the intervertebral foramen, and it may relieve some pain. So it can be done more general, like here, so where I cup the occiput and I'm just going to distract generally, looking to relieve any of the patient's symptoms. It can also be done more specific to the upper AA region. So with this method, I will stabilize at C2 and then cup my hand to still pull and distract on the occiput. Again, just looking to relieve any of the patient's symptoms. The anterior shear test is done to assess ligamentous stability of the upper C-spine. I'm going to start by finding the posterior arch of C1 on the patient by using my fingers. I'm coming off the occiput and going to C1, and then I'm going to lift the patient's head like that up towards the ceiling, and a reproduction of the patient's symptoms including double vision, nystagmus, perioral numbness, or a clunk would be positive. This test can also be done down the spine, including at C2 all the way to T1 by creating that same shear. Again, looking for a reproduction of those symptoms to be a positive test result. The AA transverse shear test is going to be done to assess for upper cervical ligamentous stability. I'm going to use the lateral aspect of my hand and stabilize C2 by finding the spinous process. I'll then use my other hand to push in a transverse direction on C1 to create some shear there. So a clunk or reproduction of the patient's nystagmus, double vision, dizziness, or numbness would all indicate a positive result and ligamentous instability. The first neurological test for the C-spine is a brachial plexus compression test. So I'm going to locate the patient's upper traps, and I'm going to come in and compress posteriorly to the clavicle, compressing on the brachial plexus and holding here. I'm going to assess, this is the uninvolved side first, but I can move over to the involved side, doing the same thing, compressing at the brachial plexus, and a positive test result would be reproducing his complaints of paresthesia or pain. The C-spine distraction test is a neurological test done if the patient is having radicular complaints. I'm going to use the heel of my hands to come underneath his occiput, and with the patient relaxed, I'll apply some distraction and make sure to hold this for 30 seconds. A positive test result would be relieving his complaints or symptoms. The Sperling's compression test is a neurological test for the C-spine. If the patient has radicular complaints on his right side, then I'm going to test the left uninvolved side first and then compare it to the right. So I'll have the patient side bend his head to the left, and then I'll apply a compression force, and then I'll have him side bend to the right, his involved side, and provide the compression again. A positive response would be a reproduction of his symptoms, but say this wasn't provocative, I could then add some cervical flexion and repeat this by having him side bend to the uninvolved side and then to the involved side, looking for a reproduction of his complaints. And if this still wasn't provocative, I could then place his head, have him slightly extend backwards with side bending, and then applying compression to the uninvolved, comparing to the involved side, and again, a positive response would be a reproduction of his neurological complaints. Jackson's compression test is going to be done if the patient is complaining of neurological symptoms in the C-spine. I'll first have the patient rotate his head to the left, which is the uninvolved side, and I'll apply a downward compression force. I'll then compare this to the involved side by having him rotate to the right while I provide that compression, and a positive test would be reproducing his complaints on the involved side with rotation and the compression. The C-spine shoulder abduction relief test is a simple test done to assess for neurological complaints in the C-spine. I'm instructing the patient to bring his arm into abduction and rest his hand on the top of the head like this. The test would be positive if this position relieves any of his neurological complaints. I can then have the patient compare it to the involved side, say if we tested the uninvolved side first, again looking for a reproduction of his complaints. The median nerve upper limb tension test is going to be done to differentiate between a nerve root versus peripheral nerve problem. So first I'm going to depress the patient's scapula and bring his arm into about 90 to 100 degrees of abduction, and then supination, external rotation, wrist extension, and then lastly I'm going to extend the patient's elbow out. So if this reproduces the patient's complaints of paresthesia or numbness, that is a positive test result. But make sure you always compare this to the uninvolved side. I can then further sensitize the test by having the patient side bend away and see if this reproduces any symptoms. The next upper limb tension test is for the radial nerve. So first I'm going to stabilize the patient's shoulder, and I'll support his arm with my leg. I'm going to have him cover his fingers with his thumb, and then I'm going to bring his arm into about 10 degrees of abduction, pronation, wrist flexion, followed by elbow extension last. A positive test response would be reproduction of the patient's symptoms along the radial distribution, but I can have him side bend away to further sensitize this test. The final upper limb tension test is going to be for the ulnar nerve. So I'm going to start by depressing the scapula and bringing the arm into abduction and back while bringing the hand towards his ear with his palm up like that, and then I'm going to see if this reproduces his symptoms, but to further sensitize the test I can have him side bend away, and a positive test result would be pain or paresthesia in the ulnar nerve distribution. The Learmite sign test is done for suspected cervical myelopathy with an upper motor neuron lesion, so I'm going to have the patient long sitting and have him bend down his head and flex his neck while I'll perform a passive straight leg raise. A positive response would be a sharp electric-like pain which goes down into the involved extremity, which would indicate a upper motor neuron lesion. The Haughton's test is a vascular clearing test, which is done two different ways. First, I'm going to have the patient bring his arms up with his palms up and have him shut his eyes. I'm going to have him stay here for 30 minutes and make sure his arms stay still. Say if the arm moves with the eyes shut, this would represent a non-vascular problem. But then I'll have him repeat the test to going into that same exact position with his palms up, but now I'm going to have him turn his head and look back over his shoulder, which reproduces side bending, extension, and rotation. Say if his arm drops with his eyes shut, this would represent a vascular issue due to the side being shut down. The C-spine vertebral artery quadrant test is a vascular screening test that is necessary to do before MOBs or MNIPs in the C-spine. So this test is done in cervical extension, side bending, and rotation. So I'm going to have the patient keep his eyes open during this test for 30 seconds, and I'm going to check for a nystagmus, dizziness, or any of the other 5Ds. This would indicate a positive test result, and therefore the patient is not cleared to do any MNIPs if he displays these symptoms. To assess for first rib mobility, I'm going to palpate posterior to the clavicle bilaterally on the first rib, and then I'm going to have the patient take a deep breath in and out, and I'll note if there is any asymmetries or reproduction of his symptoms, which is a positive test result. I'll then have him side bend his head to the left and then to the right, and then when he does this, I feel the rib in the opposite hand of the side he's side bends to. A positive test result, again, would be asymmetry. The first test I can do to assess for thoracic outlet syndrome is Adson's vascular test. So what I'm going to do is I'm going to palpate for the patient's radial pulse, and I'm going to bring his arm into slight extension and external rotation, and I'm going to see if once he rotates his head towards the ipsilateral side and then takes a deep breath in, if the pulse diminishes once he does this or is absent, that would be a positive test response. Another test assessing for thoracic outlet syndrome is the costoclavicular test. So I'm going to put my hand over the costoclavicular region and bring the patient's arm into extension, external rotation, and slight abduction. And a positive test result would be a diminished or absent pulse in this position, as well as an impingement of the thoracic outlet over the costoclavicular region. Another test to assess for thoracic outlet syndrome is the ruse test. So I'm going to have him make this position like a goalpost here with his arms, and I'm going to have him open and close his hands actively for 3 minutes. And this can check for both neurological complaints, which would indicate a positive test result by numbness or tingling, or as well as assess for vascular complaints, which would be indicated by changing in temperature of the skin or discoloration as well, both indicating a positive test response. Another test to assess for possible thoracic outlet syndrome is called the Wright's test. So I'm going to abduct the patient's arm to about 180 degrees as far as he can go here and externally rotate his arm. I'm feeling for the radial pulse to see if it is diminished or absent, which would indicate a positive test result. The next test for assessing for thoracic outlet syndrome is the shoulder girdle passive elevation test. So the patient needs to be having some symptoms for this test, and to perform it I have him cross his arms over his shoulders, and I'm going to passively elevate his shoulders here and hold this for 30 seconds. And this puts the thoracic outlet on slack, and a positive test would be alleviating his symptoms. For reflex testing at the brachioradialis muscle C5-C6, I'm going to come about 3 centimeters above the radial styloid process and find that tendon, and tapping over my thumb, I will elicit a involuntary response. Next, I will be assessing the biceps reflex of C6. So with his arm slightly flexed, I'm going to palpate for the biceps tendon and then strike it with my reflex hammer to elicit a involuntary contraction of the biceps. The next reflex I will be testing is triceps at C7. So I'm going to make sure the patient's arm is relaxed in this position and tap just proximally to the elbow to elicit a involuntary response of the triceps. The next test I'll be doing is the jaw jerk reflex. So I'm going to place my thumb right under the patient's bottom lip on his chin, and I'm going to use the reflex hammer to tap on my thumb, and a normal response is just a slight closure of the jaw, which the patient demonstrates, but an abnormal response would be a brisk, complete closure of the jaw, indicating an upper motor neuron lesion. In this video, I will be palpating the patient's masseter muscle. So I come just below the zygomatic arch on the jawline of the patient and ask him to clench his teeth. Using my thumbs, I feel extraorally the masseter muscle contracting, and the contraction is felt symmetrically on both sides. In this video, I will be palpating the patient's temporalis muscle by just going in by his temples on both sides, and I'm going to ask him to clench his teeth, and I'll feel that equal symmetrical contraction of the temporalis. In this video, I will be palpating the medial and lateral pterygoid muscles. So first, to palpate the medial pterygoid, I go in with one finger and I palpate along the inner aspect of the lower teeth intraorally, and I have the patient deviate his jaw so I can feel the contraction of that muscle. I can also palpate the lateral pterygoid intraorally, but for this muscle I'm going to be palpating on the outer aspect of the upper teeth, again having the patient deviate his jaw so I can feel the contraction of that muscle. In this video, I'll be instructing my patient first on how to find the resting position of his tongue. So I want you to make this clicking sound like this. Okay, so I want you to now go like you're about to make that sound, but don't. Right, so notice that position, that's the resting position of your tongue, where your tongue is on the roof of your mouth like that. And you can be conscious of this and practice that throughout the day.